in King County. Our reported cases have been slowly declining since late May, although they do remain higher than all past peaks, except the Omicron wave, when you consider unreported cases, which are particularly high in the current outbreak. Our surveillance trends are consistent with data from our wastewater monitoring program, which is available on the CDC website, which also shows a decrease in virus in wastewater. There's still a lot of COVID-19 out there, but we are moving in a better direction. Our hospitalizations are trending down, but less markedly and less rapidly than cases. In the past 30 days, about 60% of our hospitalizations have been in people over 70 years of age. 28% have been in adults between 20 and 59 years of age, and only 6% in people under 20 years of age. Due to our high levels of vaccination coverage among older adults, deaths did not spike during the BA.5 wave, but have held steady at about 2 to 3 per day. Now that's a significant number, but I'm happy to say it didn't spike up. I'd like to see it go down, however. People who are not fully vaccinated are much more likely to be hospitalized or die than people who are vaccinated and boosted, and that continues to hold. Because many people are not up to date with all recommended booster doses, we're missing opportunities to prevent cases, hospitalizations, and deaths. For example, although 87% of people who are 5 and older have completed a primary vaccination series, only 44% of them are up to date with all their boosters. Now, booster rates are higher in older adults. Most adults, over 90%, who are 65 years of age and older, have received the first booster dose, but a large number, 44%, have not received the recommended second booster, and that puts them at increased risk for hospitalization and death. We know that boosters lower the risk for hospitalization and they save lives. We also continue to see disparities in vaccination coverage by race and ethnicity. Another important point that we need to keep in mind when we talk about COVID in general is that we don't recognize the impacts of long COVID in our currently measured surveillance metrics, neither at the state nor local level. And we do know that long COVID is a significant problem for a minority of people who get infected, but when so many get infected, that adds up to a significant number of people. We need better data on long COVID incidence, on long COVID outcomes, on risk factors, including what role the variant you're infected with plays, your age, your vaccination status, your underlying health conditions, what's the risk with reinfection, and what's the role of genetic predisposition. A lot of questions to answer about long COVID. My best guess is that we're going to continue to see periodic surges in COVID-19 disease, and it's still not possible to predict with certainty how often or how severe. It really depends on our population level immunity from vaccination, vaccination plus past infection, how new variants evolve with respect to severity, transmissibility, and their ability to dodge immunity. The bottom line is that hospitalizations and deaths from COVID-19 are decreasing or stable, but still at substantial levels. Our current overall hospitalization rate is comparable to our average peak seasonal influenza rate, and the greatest impact is on older adults and those who are not up to date on vaccinations. If our deaths continue at the current level, it would mean approximately 700 to 1,100 King County residents dying each year in King County, and over 140,000 deaths in the US, compared with 12 to 52,000 deaths for flu, for example. And that's too many deaths that we do not want to experience going forward. And we know that we can limit both current and future infections, hospitalizations, and deaths by using sustainable, long-term, layered strategies that we know work. And these include, most importantly, being up to date with all vaccine doses and boosters. Businesses, schools, and other public spaces need to take steps to improve indoor air quality through ventilation, filtration, sometimes UV germicidal irradiation, and a combination of those strategies. Everyone needs to know about the availability of treatment and take advantage of that treatment if you have a high-risk medical condition or you're 65 and older. And those who are immunocompromised should take advantage of preventive treatment. We have information about that on our website and on the Washington State Department of Health website. High quality, and I mean N95, KN95, or KF94 masks are recommended in indoor public settings when transmission is high, including currently, and anytime it's desirable to reduce risk. And testing when you have symptoms and before indoor gatherings with high-risk people, if exposed to someone with COVID-19, and when leaving isolation if possible, is an important disease control strategy. Now I'm going to change gears and give you an update on the monkeypox situation. As of Monday, yesterday, August 8th, there have been 155 cases of monkeypox reported in King County. While anyone who has close contact with a person with monkeypox can become infected, in King County, nationally, and globally, cases have been largely among men who report close, intimate contact with other men. In King County, all of our cases have been in this group. This includes people assigned male gender at birth. Many of those interviewed to date report sexual or close, intimate contact with other men, sometimes with anonymous or multiple partners during the exposure period. And that seems to be the highest risk factor that's been identified globally. Multiple sex partners, anonymous sex partners, and male sex with other males. So we are continuing to conduct our case interviews, but based on the available data, I can tell you that the majority of cases in the past few weeks were likely exposed locally in King County. About 3/4 of those cases are residents who live in Seattle, 15% in South King County, 7% east of Seattle, and 4% north of Seattle. Majority of cases are in men 18 to 49 years of age, and they identify, 52% of this group identify as white, 25% identify as Hispanic and Latinx, and 3% of cases have been hospitalized during the course of their illness for symptoms. No patients are currently in the hospital. So based on what we know from the current epidemiology, there are ways to lower the risk of monkeypox infection if you're in the high-risk group. First of all, talk to your partner about any recent illnesses, rashes, and be aware of any new or unexplained sores or rashes on your body or your partner's body, and particularly rashes on the genitals or anus, mouth, skin. They can appear anywhere. They can be subtle. They may not be recognized as something you might think is monkeypox, but it's very important to get checked out. Limit the number of sex and intimate contact partners. For example, some have proposed sex pods with fewer partners that limit the risk. Wait a period after sexual contact to make sure symptoms don't develop, and so on, without engaging with a larger number of sex partners or anonymous sex partners. That will help lower your risk of coming in contact with the virus. Condoms may also offer partial protection because they can help prevent skin-to-skin contact, especially if there are sores or rashes on the genitals or around the anus. It's important also to decrease risk by avoiding venues where people are wearing minimal clothing and where there's direct, intimate skin-to-skin contact. So for those who do attend these venues, avoiding coming in contact with anyone with a rash or sore, if you can, is really important, and minimizing skin-to-skin contact is important. Events where people are fully clothed and unlikely to share skin-to-skin contact are safer. However, attendees still should be mindful of the risk of activities like kissing that could spread monkeypox if someone is infected. If you do develop a new unexplained rash or lesions on any part of the body, cover them with clothing or bandages, avoid sex and other close intimate contact, and get checked out by your healthcare provider. I want to switch and talk a little about vaccination. Our supply of vaccines to prevent infection from monkeypox are extremely limited. We have not received enough vaccine to reach all those who may be at high risk. For context, we estimate there are approximately 20,000 people at high risk for monkeypox exposure in King County, and another 20,000 who may also be at increased risk. At this time, we estimate the potential need for vaccine doses, therefore, to be around 40,000 people. To date, we've received 9,000 doses of Jynneos vaccine, including 4,440 that arrived last Friday, the 5th of August, and that's about 11% of the current estimated need. So in this vaccine scarce environment, we're using multiple strategies to reach those at highest risk, which again is currently men who report sex with other men who have multiple sexual or intimate contact partners. So a bit more about the distribution to vaccine and how we're going about this. The 4,720 doses that were received prior to August 5th were already completely distributed. The 4,400 doses that we received on Friday, August 5th, have started moving out into the community from our depot, but it will take some time for all the vaccine to be transferred to our community-based immunizers. And we need to coordinate with those providers on how much vaccine they need at any given time based on their ability to deliver it. And this is in process now. We're distributing about 1/3 of the vaccine to community-based providers who already care for people at high risk based on the current epidemiology, which I described. We're distributing about 1/3 of vaccine to our sexual health clinic at Harborview Medical Center, which is the largest provider of medical care to men who have sex with men in King County. And they are vaccinating people at high risk of recent exposure. And we're also facilitating additional access points in partnership with healthcare partners, community-based organizations, and businesses that have connections and interest in reaching those who may have less access to traditional healthcare providers, and particularly providing weekend access to these folks. We're also reserving a number of doses for high-risk exposures to known cases, such as this is known as post-exposure prophylaxis, and a number of doses will be stored to allow us to be nimble if we see something change with the epidemiology and we need to vaccinate a larger group of people more quickly. For example, a large number of exposures to one or more cases. The latest information we have from Washington State Department of Health is that the next date that doses can be ordered from the federal government is August 15th. So we anticipate receiving a likely between 4,000 and 5,000 additional doses after that time. Now, I know that our public health team, our community partners, our healthcare providers who are working hard to get vaccine out equitably and quickly are feeling the stress and challenge of not having enough vaccine right now. Members of our community are tremendously caring. They care about their health and the health of one another, and it's particularly difficult right now when the need for vaccine far exceeds the supply. We hope that in the coming weeks and months, we'll have access to more doses and can move those out quickly and equitably. And before I wrap up, I just want to make a few comments about questions we've been getting about the risk of monkeypox and children. And the risk to children is very low. I still want to take a few minutes to talk about this because we get lots of questions from parents at child cares and schools. So here's what we know. During the current outbreak, the risk of a child being infected is extremely low. As of August 3rd, there are about 9,000 cases in the US and only 2 pediatric cases have been reported. So that's very much less than 1/10 of 1%. It's a few hundredths of 1%. And from what we know from transmission of monkeypox in the current outbreak, the disease is being spread through direct contact with monkeypox rash, scabs, or body fluids from a person with monkeypox. It's also good to know that monkeypox and COVID-19 spread in different ways. COVID spreads primarily through the air, and monkey spreads primarily through direct close contact that can happen during intimate contact. Now, there's still a lot to learn about how monkeypox spreads through respiratory secretions like kissing, hugging, and prolonged face-to-face contact. But everything we know about it suggests it does not spread readily through the airborne route. Now, transmission can occur by touching fabrics and clothing used by someone with monkeypox, bedding. It's unclear how much of a risk that is in the current outbreak. To date, all cases in King County for which we have data are attributed to close interpersonal, intimate skin-to-skin contact. So while the risk to children in the US is currently low, childcares and schools should be aware of monkeypox and should continue to follow standard hygiene practices that prevent monkeypox and other infections that are common among children. And these include washing and sanitizing bedding in childcare settings after each use, if used by more than one child, ensuring good environmental cleaning, ensuring access to hand washing, soap and water, or hand sanitizer with at least 60% alcohol. And again, just good common sense practices about identifying children who are ill, having them evaluated and not participate in group setting like school or childcare if they're showing signs of illness or an unexplained rash. Instead, they should be evaluated by a healthcare provider. So with that, I'm going to pause. We have plenty of time to take questions.
Great. Thanks so much, Dr. Duchin. And I was getting a question also in the chat, just to have you clarify, when we talk about our cases and mentioned gender assigned at birth, what that means, and what does that include?
Yeah, so gender assigned at birth. So the group that's being impacted by monkeypox currently are men who have sex with men, particularly men who have sex with large numbers of others, and who have anonymous sex partners. And this includes people who were identified at birth as gender male, but may identify differently currently. So that could include, for example, transgender people.
Great, thanks so much. And I know from our data that it also includes folks with non-binary genders or genderqueer individuals or other identities. So we will be aware to be inclusive on that. So thank you. So let's take a question from Matt Baum. And if you can, please share also your news outlet. You can go ahead.
Hi, thanks so much. This is Matt Baum at The Stranger. I'm just curious, because the supply is so limited, is there any opportunity here to request international aid?
Not that I'm aware, Matt. I know that there is a tremendous demand for this vaccine globally, that many countries were able to place orders for vaccine with the manufacturer Jynneos ahead of the US, which is one of the reasons we are in a bit of a bind with respect to the supply and demand currently. But through my discussions with partners at the state, local, and federal level, I have not heard any talk or heard of any opportunities to receive vaccine from other countries.
Thanks. We can take a question from QW. It looks like it may be Paige.
Hi there. Thanks for taking our questions, Doctor. I'm wondering first about the prevention tactics. If I'm high risk, but I'm already not having sex with multiple partners, how concerned should I be about being out in public? You know, we have numerous community spaces, nightclubs, et cetera, where at-risk populations regularly gather, and people not at risk are in those spaces, dancing, meeting people. So I'm wondering what advice you have, if you could elaborate on your advice outside of limiting sexual partners.
So thank you for your question. The disease spreads primarily through skin-to-skin contact, but can also spread through prolonged face-to-face contact through respiratory droplets. Those are the main ways that the disease spreads. It can also spread through contact with contaminated objects and clothing. So if you can avoid that close, intimate skin-to-skin contact with people who are known to have monkeypox, known to be at high risk, or populations known to be at high risk, that's going to be the most effective prevention measure. Just interrupting that physical opportunity for the virus to move from one person to the next. Now, in King County, we have about 2% of the cases nationally. We do not have a giant outbreak, but we do have a real outbreak, and it's a real important outbreak, and it's something that we're taking extremely seriously. But I think that everyone needs to understand the environment in which they're in, the likelihood that other people in that environment would be in the high risk group. In other words, people who have large numbers of sexual partners, men who have sex with men who have large numbers of sexual partners. And if in that environment, if you choose to be in that environment, just taking steps to minimize your risk through limiting or avoiding close skin to skin or contact primarily, and avoiding respiratory close, very close, prolonged respiratory contact. Now that's defined by CDC as several hours, so it's not casual contact. So again, right now, the main risk factor that we're identifying in our cases are men who have had known contact with multiple other men, intimate contact, sexual contact, and that's the way the disease is spreading. And that's where the bulk of our prevention efforts need to go, and helping those high-risk groups understand what they can do to limit their risk by decreasing those high-risk contacts and by getting vaccine out to the people at the highest risk. And as we get more vaccine, sequentially offering it to people at somewhat lower risk.
Great, and we'll try and go through all the first questions that we have, and if there's time, then we can allow for follow-up. So let's take a question from Andy Ingelston. You can go ahead.
Great, thank you so much for taking our questions today. So I know that public health has said that, and I'm sorry, I'm with Crosscut for this piece. I wonder if public health is planning to reach out to communities that are higher risk that you've noted. So for instance, are you planning to set up clinics at bathhouses? Are you going to set up a clinic in homeless encampments to reduce those barriers of getting the vaccine to those at-risk communities?
Absolutely. That is a key part of our strategy to work with community partners, including bathhouse operators and other organizations who advocate for and can represent the interests of the people who are currently being most impacted, working with them to understand what are the best venues for delivering vaccine, the best providers, the best ways to get access to those highest risk groups. So that is actively going on currently.
Thanks, and we can take a question from Dee Dee Sun. You can go ahead.
Hi, Dr. Duchin. I have a question about the Biden administration's plan to stretch the limited vaccine supply. I think it was just this afternoon that the administration said that they're, launching plans to have the CDC train doctors on intradermal vaccination where it can, stretch that 1 dose to 5 doses. Can you talk a little bit about that? And is that in the plans yet for King County, or are you waiting for further guidance from the CDC?
So this is, just happened a few minutes ago. So we are waiting to hear the full guidance and what they call clinical considerations. But basically, if this is carried out, this will expand the vaccine supply. So instead, what used to be 1 dose will now be 5 doses. It's a just slightly different way to administer the vaccine. It's the way we used to do and sometimes still do what's called a TST, tuberculous skin test, with a very fine needle that just puts the dosage into the skin instead of under the skin, which is where the single dose approach delivers the vaccine. And it does entail having that skill, that ability to accurately deliver the vaccine using the fine needle into the skin. And so our colleagues who have worked in tuberculosis are very well familiar with this technique. We will have to identify other vaccinators in the community who are comfortable and willing to deliver vaccine by this route, and I don't anticipate that will be a problem. It may take a few hours of training, but it's not a complicated concept, and it's not difficult physically. It just requires some care and attention to do it properly. So, there are a number of details that we're waiting to hear from our federal partners about. For example, when we would start this approach, where we would get the supply of needles, and whether there are going to be standardized training materials that they want us to use to engage our clinical colleagues so that they can deliver the vaccine through this route. information materials for patients about this option for vaccination, how it differs from the previous route of administration, what that means about side effects. And just parenthetically, I can tell you that the side effects that have been studied the side effects that have appeared when this vaccine was studied when delivered through the intradermal route compared to subcutaneous are not very serious. Typically, some redness and itching at the site, but it may last a little bit longer than the pain that usually you get with a subcutaneous injection. So local side effects, redness, itching, but that can last for a bit. But this is an example of the type of information that we want to share with the community who are going to receive the vaccine, so they know what to expect. So yes, we're anxiously awaiting further guidance on this late-breaking development from both the FDA and particularly from the CDC, who is our main partner in providing vaccine administration standards, both to local health and to the community. So I anticipate over the next few days, we'll be getting more information about that. And then if this is rolling out the way it's been reported in the media that it's going to roll out, we'll be recruiting and working with clinical healthcare providers in the community to ensure that they're able and willing to deliver vaccine through this new administration route, and then delivering it to them to be able to vaccinate 5 times as many people as we would have otherwise.
So just to clarify, not that clearly wouldn't happen by the pop-up clinic this weekend, right?
Unlikely.
Yeah.
It'd be difficult, but not impossible.
Right.
The world has been very unpredictable. My world has been very unpredictable for the last 2.5 years. And I hesitate to say anything with certainty, but I would doubt that we'd be able to pivot to this new sort of way of doing things as early as this weekend. But I would not say it's out of the question.
Thank you, Dr. Duchin.
Thank you. Let's take a question from Brady, it looks like from King 5 News.
Hey, doctor, thank you so much for your time. Yeah, one quick question that we had for you is just back to the monkeypox vaccines. Obviously, they're certainly limited at this time, but again, where can people get these vaccines, and are there going to be any other, vaccine clinics like we had over the weekend in King County? And if so, are there going to be, where would they be located? And secondly, would they be every day, or is it just the weekends? But yeah, again, the big question is, where can people get these vaccines?
Mm-hmm. Yeah, I'm hoping maybe our team can put in the chat links to the information that we have for the public about access to vaccines. Right now, there are several healthcare providers in the county that are offering vaccine to their patients, but also to some people who are not their patients. And then also the sexual health clinic in Harborview, of course. And yes, we will be planning some community vaccination events. They're not going to be on a regular schedule because we just don't have enough vaccine for that. But when we have adequate vaccine, we'll plan. And those sometimes will be advertised, and sometimes they'll be done through a community partner who already is engaged with a high-risk group. So that will be all, sort of determine the frequency of those types of activities, and the number of people that can be vaccinated at them will be, determined by what happens with this new policy around route of administration. So if we are able to increase the number of doses 5-fold, that will allow us to do more of these types of events. And the best place to find information will be on our website, the vaccination page on our website, and then also through community groups that work with high-risk populations.
Thank you.
Thank you. We'll take a question from Michelle Esteban. You can go ahead.
Very much. I appreciate that. Thank you, Dr. Duchin, for your time and availability today. I wanted to go back to something you said, and that is we need potentially 40,000 vaccines in King County. And even if it's just 20,000, we're far away from that. I want to know your thoughts on declaring a monkeypox health emergency. I know that community-based groups and stakeholders have reached out to the governor asking that. We reached out to the governor as well. Where are you with regard to, are we there? Because certainly what I'm understanding is if that happens, then perhaps the ultimate goal here would be to get more vaccine and to get it more quickly in real time.
It's an interesting question. I am not aware that declaring an emergency is going to allow us to have more vaccine. The vaccine we get is allocated from the federal government. And although declaring a public health emergency at times can help us with resource needs, around delivery of vaccine and having teams in place and reimbursement for different activities. As far as I know, it's not going to give us more vaccines available. So I don't personally at this point know how if that would be a useful way to expand the vaccine supply.
Thank you.
Thank you. If you have follow-up questions, you can go ahead and raise your hand. I do have some questions coming in from the community, Dr. Duchin. So one, just to clarify, and I've got this question quite a bit, is some of the discrepancies between the numbers of cases that may be reported on our King County monkeypox webpage versus what's reported from DOH. And I know from what I know, it has to do with a website update timing. So we update our cases every day at 1 o'clock. So sometimes DOH's numbers may be updated a little bit earlier, a little bit later than that. And I know because when we were doing this briefing, our website just got updated with new numbers. You can check that out. I believe now our update is up to 183 cases. But again, we just updated that. So for your news coverage, you can look at our daily case count that gets updated at 1 o'clock. But again, it has to do with website updates and when that data gets updated to DOH and us. So just a clarification, but anything else you wanted to add on that?
No, that was perfect. Thank you.
Okay, great. And then a question about zoonotic disease. So we know that some of the earlier outbreaks that were not in this recent outbreak, we saw transmission via animals and infected animals, but a good question here about, are there any confirmed cases of transmission due to contact with infected animals that you know of in this outbreak overall? Is there any preparation around that or concern that this outbreak could move more towards a zoonotic outbreak as well?
Okay, so good questions. I am not aware of any cases acquired through contact with animals in this current outbreak that's affecting primarily gay and bisexual men who have sex with men, although we do know that historically in some cases that have occurred in Africa, that the disease is attributed to contact with wild rodents or other small mammals. So we do believe that the disease can be spread from infected animals to humans in some environments. Now this is not something that we worry about really in the U.S. currently, because we are not known to have monkeypox, in any animal species that's found in the U.S. We also don't know a lot about how easy it is. So we know that monkeypox theoretically can spread from animals to humans, but it's certainly not something that's playing a recognized role in the current outbreak. Doesn't mean that, the thing we don't know less about is transmission from humans to animals, whether that occurs, how frequently it occurs, circumstances in which it might occur, and then whether that would lead back to transmission risk to humans. There are good precautions, common sense precautions about avoiding contact with pets. If you are a known monkeypox case that are available on the CDC website, I encourage you to look at. Important for people who have known monkeypox to not only avoid close contact with other humans, but also to isolate from animals and pets. And there's good advice on what exactly that means from CDC. So at this point, it's a theoretical risk that someone could infect an animal. That doesn't necessarily mean that that animal would then lead to an outbreak in other animals or pose a risk to other humans. It's something that is really not known and right now not being observed, but something that potentially would be of interest if it did occur, and would be a subject of I think intensive study to see if there was any evidence of spread. Theoretically, if a disease is widespread in humans, there could be opportunities for exposure of animals that humans have close contact with. But that's not the case currently. And as I said, even if that did happen sporadically or intermittently, it's not clear that that would lead to an ongoing problem.
Thank you. And can we take a moment just to talk about treatment and treatment access? Can you share how somebody who may be diagnosed with a case is able to access treatment? Is that available across the county? Can you share a little bit about how that system's working?
Yeah, so there is an antiviral drug that appears to be effective against monkeypox for people who have severe infections or at high risk for severe infections. And that is accessed through your healthcare provider. So it's important, first of all, for our healthcare providers, critically important to identify monkeypox cases. Think about monkeypox in people who are at risk, have risk factors, and who have compatible illness, and that compatible illness can be a little bit subtle. So we need you to be pretty vigilant about looking for the signs and symptoms of monkeypox illness, which can include, some nondescript things like fatigue, malaise, lymphadenopathy is a clue, but particularly the rash. And the rash can be subtle and can look like other things. It can be just one lesion, a few lesions, can be anywhere on the skin, can be in the mouth, can be around the genitals, can be in the anus. So a thorough exam and a high index of suspicion, and if in doubt, test, and test. And I'm happy to say that our colleagues at the University of Washington Virology Lab are offering testing now, a very quick turnaround time, and encourage people to take advantage of that. So if you've got monkeypox, if you think you have monkeypox, seek healthcare. You should be tested promptly, and then based on your clinical illness, the severity of your clinical illness, and/or your personal medical history, you could be eligible for treatment. And I am very proud of the fact that our team has now worked with over 90 healthcare providers in King County where treatment is available throughout the county, and should not be a barrier for anyone at this point. So although I don't want people to need treatment, I very much want it to be available if and when that is necessary. And I think we have done a good job in King County. Our healthcare providers have stepped up tremendously to go through the rather onerous paperwork that the FDA requires to offer this treatment. And it is widely available.
Great. And we can, looks like, take a follow-up question from Paige. You can go ahead.
Thanks, Kate and Dr. Duchin. My follow-up is, when people are lucky enough to be able to get a vaccine and they need to fill out a form as they're at their appointment, who is seeing that information on the form, and what are the data storage practices, and how long are we going to be using these forms?
So I'm not sure I know exactly which form, but there are forms that are submitted to the Washington State Immunization Registry, because these vaccines are through the federal and state government and monitored through the Immunization Registry, and they have all the protections that any other protected health information would have, and that all other administered vaccinations have, from disclosure. And we see that data, public health people see that data, so we can both identify when someone's been vaccinated, but also identify, the ages of people who are being vaccinated. Ideally, we'd like to understand the demographics, the race and ethnic breakdown of people who've been vaccinated, although we haven't been able to see that information yet. And we also ask information about the risk factors, to ensure the eligibility. So that information comes into public health and is managed like any other public health investigation risk factor information. For instance, if you're investigating a case of hepatitis and we ask about risk factors, include things like sexual activity and other exposures, goes into a protected database.
Thank you. And a follow-up question from Diana. You can go ahead.
Thank you so much. Hi, Dr. Duchin. This is Diana Apong from KOW Public Radio. My colleague Paige and I have been, gathering this data and following the story very closely. And I just want to ask a couple clarifying questions. So, is the shortage of the vaccine due just to supply issues, or is there something else going on?
As far as I know, it's strictly supply issues. The U.S. government had a supply of vaccine prior to the outbreak that was inadequate, to meet the demands of this unanticipated outbreak. And when they went to order more, because the outbreak had been occurring for quite a while, many other countries had already placed their orders with the sole manufacturer. So to my, as far as I know, there's no other explanation for the shortage than supply.
Okay, wonderful. And then the other question I had for you regarding vaccine access is some folks are traveling outside of the area, I've heard as far as Vancouver, to get access to the vaccine. And it's my understanding that there's been sort of a phasing of this vaccine distribution, like a phase 1, phase 2, phase 3. Are you familiar with that? Could you explain that a little more?
To my knowledge, that terminology really was more not reflecting phased eligibility, other than, very early, there was only a few doses. So it was being used only for people who are in contacts of known cases, post-exposure prophylaxis, the very highest risk group, someone who knows they were in contact with a documented monkeypox case. But those phases were more in reference to the timing of release of doses. So they don't have that much of a functional, sort of correlate.
Thank you.
And I just wanted to ask a few more questions coming in. Is it too early to observe any impact of vaccination in King County?
I think so. Now, when you look at the epidemiology of an outbreak, and if there's a vaccine available, of course, vaccine can theoretically and ideally influence that the course of that outbreak to limit infections and spread of infection. But the other more rapidly effective intervention is behavior change. And so I think that as more at-risk people learn about their risk and the disease being here locally and how to limit their risk, that will also have a very strong role in how the outbreak evolves, and it will limit opportunities for the virus to move from person to person. So sorting out at this stage what, if cases started to level off or decline, sorting out what would be the role of behavior change versus vaccination, it would be difficult to impossible. And with vaccine available only for a relative small proportion of those who are at high risk, I would think behavior change would be the more influential intervention at the moment.
Helpful. And a question here that I'll just ask you. I think we're all very used to COVID and the transmission routes of COVID. And I think as we hear this news, folks have a lot of concern about whether this could be an outbreak that could grow to the size of COVID. And as people are thinking about returning back to school, is there anything that you can help say to help clarify how this may be similar to COVID, how it may be different, and what you might expect to see?
Yeah, it's very different from COVID. COVID is a respiratory infection that spreads primarily, through the air, very effectively through the air. And you can see that in the way, the outbreak has evolved to spread rapidly through all age groups and different segments of the population. Monkeypox, on the other hand, is a much more slowly moving infection that needs close, intimate contact, primarily skin-to-skin contact or contact with the bedding or other, clothing of an infected patient. Not, a lot of people are not going to be in the circumstances where they have that type of contact, and does not, based on the epidemiology of the infection, both prior to and during this current outbreak, does not suggest airborne transmission plays a significant role. Now, there are definitely reasons to be concerned about that droplets with prolonged contact, but it doesn't appear to be spread efficiently, through that route compared to the direct contact route, which is very different from COVID, which spreads very efficiently and very effectively with, casual, brief contact when it's, floating in the air. So viruses are very different with respect to their physical features, their characteristics, how much is in upper airway, how much is required to, cause an infection if it is emitted from the upper airway, how viable it is in the environment, and so on, how susceptible the respiratory mucosa is and the oral mucosa, the eye mucosa to being inoculated. Those things vary from one virus to the next. And what we know about monkeypox and what we know about COVID suggests that they spread in very different ways. And that's evident in the explosive nature of the COVID-19 outbreak, as opposed to what we're seeing with monkeypox, which is more slow and deliberate with contact through a much less efficient mechanism.
Excellent. And then just to wrap up, can you reflect a little bit about, as the public health system has gone into this response very quickly for monkeypox, what you've seen as strengths that we've learned, and I mean we broadly, the public health system, local health jurisdictions, that have allowed us to be better prepared? And then what are some of the challenges that are facing us now? I know we've been getting this contextual question from the public and media to help understand how are we responding on top of the COVID pandemic?
Yeah, well, I would say it's very difficult for our team. I mean, we've learned a lot, but the team is quite exhausted. And as you know, our federal government has not provided sustained funding for the COVID response. So we're shrinking in size of the COVID response, despite the fact that the outbreak is still quite important and still causing quite a large number of cases, hospitalizations, and deaths, and will continue to do so. So that's problematic, but we have learned a lot through our response to COVID-19. For example, the importance of engaging community and working with trusted partners to deliver healthcare services such as vaccine, antiviral drug, and risk reduction methods. The partnerships we built to basically move vaccine out, the systems, the information systems that we've built to sort of allow us to track the administration and delivery of vaccinations, both in bulk as they move from one facility to the next, but also into individuals and get those into our vaccine information systems. We have lots of experience both in the community and in the department with rapid reporting of infectious diseases. Our laboratory colleagues, for example, at the University of Washington, also now being able to get their test for monkeypox up and running so very quickly compared to what we went through with COVID, based on lessons learned from COVID, and the critical importance of testing, widespread testing, to make sure that we're not missing cases and understand the true extent of an outbreak. All these are really great lessons that we've learned, and some of which are being applied currently. Some of the challenges, again, are around lack of preparedness with respect to investment in adequate supplies and of vaccinations, The research end of things, could have been more robust and should be more robust going forward with respect to understanding the effectiveness and best ways to use vaccines. We probably should have had better protocols nationally for an unanticipated sort of event like this. But I think the fact that it's coming on top of the COVID-19 pandemic is just something that is hard to anticipate. Two unprecedented, emerging outbreaks occurring simultaneously. But I think this may be something that we're going to be seeing more frequently, just based on the emergence of the pace of emergence of infectious diseases for a number of reasons that's happening. We've also developed really good communications channels through social media and community partners to get information out to people, which has been a tremendous learning and benefit, I think, from COVID-19 that we're taking advantage of here during the monkeypox outbreak. But I think that the main challenge is that the public health and clinical workforces are extremely frazzled right now. Both hospitals, healthcare providers, and public health folks are really running on fumes and very fragile. And it's a great challenge for us to try and meet the demands of two simultaneous outbreaks. People are acting heroically, in the healthcare system every day, and in the public health system. And I know the community is also very fatigued and strained by the cumulative stress and repercussions, both physical and emotional and social and economic, of the ongoing COVID-19 outbreak. Thankfully, monkeypox is not going to be as pervasive as COVID-19, but for the community that is impacted, it's just as bad in many ways. And we need to take it just as seriously. But as far as how wide its impact will be, it's not going to be like as bad as COVID-19. But our healthcare community, our public health community, and those folks who are feeling it, are really feeling it. So my hat's off to all of you.
Thank you very much for that. I think that was a really poignant ending, but is there anything else that you wanted to share?
Just thank you again to our media partners for sticking with us for this now and going into 3 years of outbreak response, and now a double simultaneous outbreak response. The messaging is complex, it's nuanced, it's changing, it's frustrating for all of us. And having careful reporting from you is really a tremendous service to our community. So thank you for